Hello, and welcome to the University of Kentucky Anesthesia YouTube channel. My name is John Green. I'm a pediatric anesthesiologist and one of the associate program directors for our residency program here. Today's lecture is part of the keyword review series for the ABA basic content outline. This lecture is on common perioperative complications. The keywords that we're going to be reviewing today are temperature derangements, specifically hypothermia and non-malignant hyperthermia, bronchospasm, latex allergy, and laryngospasm. So we'll start with temperature derangements. So let's review the thermoregulation function of the body, which occurs in the hypothalamus and the autonomic nervous system. The core temperature of the body is very tightly regulated, and the peripheral tissues act as a buffering system for this core temperature. We have both cold-induced and warmth-induced thermoregulation mechanisms. The cold-induced mechanisms include vasoconstriction, non-shivering thermogenesis, and shivering thermogenesis, and in the warmth-induced mechanisms include vasodilation and sweating. And there is a very narrow temperature range, an interthreshold range, wherein these mechanisms begin to kick in. There's about a 0.2 degree Celsius difference from when these cold-induced and warmth-induced regulation mechanisms begin to kick in. Now, anesthesia has effects on thermoregulation. It actually affects this interthreshold range. General anesthesia increases the threshold range for the warmth-induced thermoregulation mechanisms. So in other words, those mechanisms don't kick in until a higher temperature than normal. And conversely, it decreases the threshold for the cold-induced thermoregulation. So that interthreshold range of about 0.2 degrees Celsius actually increases to around 4 degrees Celsius. So there is much more fluctuation of the core temperature of the body before these mechanisms begin to kick in. General anesthesia inhibits thermoregulation in a dose-dependent manner. Now, neuraxial anesthesia also affects the thermoregulation, albeit to a lesser level, and it's essentially dependent on the level of the blockade. So anything above the level of the blockade, the thermoregulation mechanisms are left intact. So moving on to hypothermia. So etiology for hypothermia in the operative environment. The most important one for our purposes is redistribution of heat from the core to the peripheral system due to vasodilation. You can see to the graph to the right, this redistribution is most profound in the first hour, where you can have 1 to 1.5 degrees Celsius temperature drop during that time. Over the next hour or two, it continues to drop, albeit less precipitously. And then about 3 to 5 hours after you begin anesthesia, you finally reach a steady state where heat loss is stabilized. Additional mechanisms for heat loss in the operative environment include radiation, which is heat loss from the patient to the environment or the ambient temperature of the operating room. Convection, which is heat loss due to air currents that flow over the surface of the body. Conduction, which is heat loss from actual physical contact, so transfer of heat from the patient to another object, such as a cold OR table. And then finally, evaporation, which is heat loss due to transfer of liquids or body fluids to the environment as it changes from a liquid to a gaseous state. We know that hypothermia can cause quite a few complications. So those complications include problems with coagulation by impairing platelet aggregation and reducing the activity of the enzymes that are associated with the coagulation cascade. It can predispose to infection due to reduced tissue perfusion, decreased motility of immune cells, and reduced scar formation. It can prolong the effects of some of our drugs, medications, most notably the neuromuscular blocking agents. Hypothermia can contribute to delayed emergence. It can also cause myocardial ischemia from sympathetic stimulation, and this can be very profound in those that already have an underlying cardiovascular disease. And then it contributes to postoperative shivering, which increases metabolism, increases oxygen demand and consumption, and it's generally uncomfortable for the patient as well. So, preventing and treating hypothermia, we have pre-warming techniques, passive warming, and active warming. Pre-warming is basically just warming the patient in the preoperative area before they even undergo anesthesia. This can decrease that core to peripheral temperature gradient and blunt the redistribution that we talked about that occurs over the first hour or two. There are passive warming techniques such as applying blankets, warm blankets, sterile drapes, and increasing the ambient temperature of the operating room. And then we have active warming techniques. So forced air warmer, your bear hugger, if you will, is one of the most efficient ways to prevent heat loss. You have other devices such as resistive heating blankets and water mattresses. It's important to remember that warming your IV fluids can also help prevent heat loss. Radiant warmers are very useful, especially in the pediatric population, most notably the neonatal population, which are very prone to quickly losing body heat. And then it's also important to remember that you can heat and humidify the inhaled gases via your anesthesia circuit. Now, we'll move on to hyperthermia. And again, this is non-malignant hyperthermia. This is all other causes of hyperthermia. So etiology for hyperthermia can be due to either iatrogenic causes, excessive heating such as leaving the bear hugger too high for too long, or increasing the OR temperature too much. It can be a result of drug reactions, most notably neuroleptic malignant syndrome, serotonin syndrome, or anticholinergic toxicity. Those that have underlying thyroid issues can have a thyroid storm, which can contribute significantly to hyperthermia. And then finally, hyperthermia can be due to fever. It is important to determine what the fever is from. Is it from an infectious process, or are they having a reaction to either blood products or a medication that we administered? Complications from hyperthermia are relatively simple. It increases metabolic rate, which increases the oxygen demand, and specifically myocardial oxygen demand and myocardial oxygen consumption. And quite frankly, some of our patients can't really afford this increase in myocardial oxygen consumption. Preventing and treating hyperthermia includes eliminating the cause and promoting heat loss. Unless it's an emergency, you want to avoid active cooling if possible, because this can actually activate the autonomic nervous system response or cause shivering, which are counterproductive to what we're trying to do. If the hyperthermia is due to a fever, again, it's important to identify the cause of that fever and try to correct it. In the meantime, you can administer an antipyretic such as acetaminophen. So we'll move on to bronchospasm. Put simply, bronchospasm is a spasmodic contraction of the bronchial smooth muscle. Causes are multifactorial, including histamine release due to medications. It can be a reflex bronchoconstriction due to stimulation of the parasympathetic nervous system, such as occurs with airway placement and manipulation. It can be a hypersensitivity reaction, especially if they're having an anaphylactic type reaction. Some of the medications that we use that are associated with bronchospasm include neuromuscular blockers such as succinylcholine, rocuronium, atracurium. The non-selective beta blockers, most notably those that block beta-2 receptors such as propranolol. Anticholinesterases such as neostigmine, which explains why we give glycopyrrolate with neostigmine to counteract that muscarinic choline receptor activation. And then prostaglandin inhibitors such as NSAIDs can also cause bronchospasm, especially in those that have aspirin-exacerbated asthma. Risk factors for bronchospasm essentially those that are prone to airway hyperreactivity, such as asthma, COPD. Our pediatric population is especially sensitive and prone to bronchospasm, most notably those that have had a current or a recent upper respiratory infection. And what do we mean by recent? Basically, any child that has had an upper respiratory infection within the past couple of weeks, is at risk for having bronchospasm. Those patients that have a history of atopy, with a history of eczema or hay fever, and those that have household exposure to cigarette smoke. Clinical signs of bronchospasm, you will hear wheezing and see prolonged expiration. Although it is important to realize if you have a very severe bronchospasm, you may have reduced or even absent lung sound, so you may or may not even hear the wheezing. You'll see increased airway pressure during positive pressure ventilation. Your oxygen saturation will decrease, your end-tidal CO2 will decrease, and you may or have an upsloping waveform. Again, it's important to realize if you have a very severe bronchospasm that your end-tidal CO2 reading may be very decreased or even absent. And then finally, you can have hypotension if these symptoms continue, or if there's anaphylaxis involved. So prevention of bronchospasm includes preoperative identification and assessment of these patients. You want to get an accurate assessment of their baseline status and their disease management. If their disease is poorly managed, you should consider a pulmonary consultation to see if they can be optimized prior to this procedure. Children that come with an upper respiratory infection, if this is an elective process, ideally you want to wait and postpone the procedure and have them come back anywhere from 2 to 4 weeks after their upper respiratory infection is ideal. If they've had a pneumonia, 6 weeks would be better. If they are on a maintenance beta agonist or corticosteroid, you want these patients to continue these treatments in the perioperative period and consider giving a prophylactic dose before going back to the operating room. Intraoperatively, prevention basically occurs by maintaining an adequate depth of anesthesia, especially during airway management and manipulation. IV induction is preferred, notably propofol and ketamine, because these have bronchodilating properties. IV lidocaine may also be beneficial in helping prevent bronchospasm. And then if you can just avoid an endotracheal tube, if at all possible, that would be ideal. Either using a supraglottic airway, mask, cannula, or if you can use regional anesthesia and avoid having to intubate. Management for bronchospasm should occur quickly and in a stepwise fashion. If they are on a rate on your ventilator, you want to take them off the rate, put them on manual, hand ventilate, and increase your FiO2 to 100%. You want to also take lung sounds if at all possible, and you want to confirm tube placement and patency. And you want to try to identify or rule out any potential non-bronchospasm causes. So if you want to rule out an obstruction of your tube, be it from kinking or a mucus plug, you want to rule out tension pneumothorax, pulmonary edema, aspiration, things like that. You want to deepen your anesthetic, and you can either do this with volatile anesthetic or intravenous agent, keeping in mind that if you have a very severe bronchospasm and you're not getting airway movement, increasing your volatile anesthetic is not going to help because it's not getting down to the alveoli, so you're going to have to use an intravenous agent to deepen the anesthetic. A beta agonist such as albuterol should be utilized either with an inhaler or a nebulizer. If you're using an inhaler, ideally if you can use a device to put it into the anesthesia circuit rather than just squirting it down the tube. If these don't work, then you need to resort to epinephrine IV. Small boluses such as 0.1 to 1 mic per kilogram boluses. If they have anaphylaxis or severe hypotension, you might need to increase that bolus to 10 to 100 mics per kilogram IV or consider continuous infusion. Additional medications to consider, a magnesium loading dose can help. Steroids, be it solumedrol, hydrocortisone, or dexamethasone. and then a beta agonist such as terbutaline can be given subcutaneously. So we'll move on to latex allergy. So the latex antigen can enter the body primarily through skin and mucous membranes, but it can also enter via the wound, via the bloodstream, or via an ingestion. Potential sources for latex antigens include gloves, urinary catheters, tourniquets, the rubber in the plungers of the syringe or the vial stopper, and then IV catheters. Latex allergies tend to be one of two hypersensitivity reactions. You can actually have an anaphylaxis, which is a type 1 reaction. In fact, latex allergy is the second most common cause for anaphylaxis associated with anesthesia. You can also have a contact dermatitis, which is a type 4 hypersensitivity reaction. In either of these, you have a prior exposure, and then upon re-exposure to the allergen, it actually cross-links the IgE antibodies on the effector cells, the mast cells, and the basophils. It causes the release of the chemicals histamine, tryptase, and carboxypeptidase A, which causes the activation of the enzymes phospholipase A2, cyclooxygenase, and lipoxygenase, which release these chemical mediators of the immune system, prostaglandins, leukotrienes, and cytokines. It's important to understand that the time of exposure to onset of symptoms varies widely. This can occur within 5 minutes of exposure or 2.5 hours after the exposure. And this is important because you can actually, on a shorter procedure, you could drop off your patient in the recovery room and not see anything until they're actually in the recovery room. Risk factors for latex allergy. Children that undergo multiple surgical procedures or procedures at a very young age, most notably those with spina bifida. Those patients that have a history of, again, atopy. Allergies to certain fruits, so banana, chestnut, avocado seem to be the primary players in this. And then healthcare professionals are at increased risk for developing latex allergy. Clinical signs of latex allergy can be as relatively mild as dermatologic symptoms such as rash or urticaria. You may develop bronchospasm or wheezing. If you have anaphylaxis, you may see angioedema, stridor, hypotension, or cardiovascular collapse. Prevention for latex allergy, again, preoperative identification and risk assessment, and then utilization of latex-free protocols. Management of a latex allergy reaction includes removal of the antigen, administration of epinephrine boluses, possibly even a continuous infusion, and then IV crystalloid fluid boluses. Additional medications to consider include a beta agonist such as albuterol, antihistamines such as diphenhydramine or ranitidine, IV corticosteroids, and then it's also important to remember that you can do tryptase testing or allergy testing, especially if you have a suspicion for a reaction with an undiagnosed latex allergy. All right, finally we'll go to laryngospasm. So laryngospasm is a sustained closure of the vocal cords which results in airway obstruction. You can see the image to the right, the vocal cord muscles and their action with adduction of the vocal cords. And it's important to realize that this may also involve the false vocal cords or even the supraglottic tissue because of the translaryngeal pressure gradient. Laryngospasm is triggered by either a mechanical, chemical, or a thermal stimulus around the glottis, and this occurs via the vagus nerve. And the sensory input is from the internal branch of the superior laryngeal nerve. The motor function occurs via the recurrent laryngeal nerve, which controls the lateral cricoarytenoids, the thyroarytenoids, and the transverse and oblique arytenoid muscles. And then the external branch of the superior laryngeal nerve controls the cricothyroid muscles. Risk factors for laryngospasm are multiple. Insufficient depth of anesthesia is one of the primary risk factors, especially with induction and emergence. Airway irritation is another prime risk factor. Now, airway irritation can occur via manipulation, such as with laryngoscopy, suctioning. Even an oral airway can irritate the airway. Secretions in the oropharynx, be it blood, mucus, or even saliva, can cause airway irritation. And then volatile anesthetics can cause irritation. You can see the desflurane tends to be the most irritating, followed by isoflurane and then sevoflurane. This partially explains why we use sevoflurane for mask induction with children, because it is relatively the least irritating of the volatile anesthetics that we commonly use. Age is inversely correlated. So the younger your patient is, the more prone they are to laryngospasm. Those that have an underlying airway hyperreactivity, so those with asthma, current or recent upper respiratory tract infection, or household tobacco smoke exposure. Obesity, sleep apnea, and reflux are all additional risk factors for laryngospasm. Those that have an underlying airway anomaly are at risk, and then there are certain procedures that tend to be associated with laryngospasm, most notably tonsils and adenoidectomy, endoscopic or bronchoscopic procedures, and thyroid surgery. Clinical signs of laryngospasm, you may hear inspiratory stridor. Again, it's important to realize if you have a complete laryngospasm where you have absence of any air movement, you will not hear any of this stridor. You'll see paradoxical respiratory movements and supraclavicular suprasternal retractions. Your oxygen saturation will very rapidly decrease, and if uncorrected, this can lead to bradycardia, things like negative pressure pulmonary edema or pulmonary aspiration. You can even have cardiac arrest. Prevention for laryngospasm. Propofol can help prevent. Lidocaine given before extubation, either intravenously or vocal cord topicalization, can help prevent laryngospasm. A small magnesium bolus IV can also help prevent it. And then one of the main things is just ensure that there are no blood or secretions in the hypopharynx before extubation. Management for laryngospasm must occur very quickly. This is an algorithm that just must be memorized and quickly proceed through this, because the laryngospasm can decompensate within a matter of 15 to 20 seconds. So one of the most important things is to actually recognize the laryngospasm as early as possible. You want to look for the signs and have a high index of suspicion, especially if they have risk factors, and you want to recognize it early. You want to remove the stimulus if at all possible. So if you are suctioning and you have a laryngospasm, obviously stop the suctioning. And the first thing that you really need to do is kind of a combination. You want to do a jaw thrust and continuous positive airway pressure. Usually, this will break the spasm. If it does not, then you need to rapidly progress to the next step, which would be to give a propofol IV bolus. And if that doesn't work, you need to resort to giving succinylcholine. If you have an IV, your dose is 0.1 to 0.2 milligram per kilogram. If you don't have an IV, you can give it intramuscular at 4 to 5 milligrams per kilogram. Some other anecdotal options, and anecdotal is in quotes just because there's less evidence for these techniques. You can do Larson's maneuver, which is bilateral pressure in the laryngospasm notch. The laryngospasm notch is just below or behind the pinna of the ear, bordered by the mastoid process posteriorly and the condyle of the mandible anteriorly. So if you do bilateral, firm inward and anterior pressure in this notch, that's Larson's maneuver. I'm actually a big proponent of Larson's maneuver, and this is what I utilize to do my jaw thrust if this occurs. Another anecdotal option, which I have not tried, is gentle chest compressions. And again, this is gentle chest compressions, gentle, rapid, shallow compression of the chest. This is not CPR chest compressions, but it has been shown that this may be beneficial in helping break the spasm. Okay, that's the end of the lecture. These are my references. I hope that you got something out of it, and thank you for visiting our channel.